This is Dr. Gordon Elder, Director of the Blair Chiropractic Clinic. It's February 15th, 2025, and I want to just document exactly how I am currently analyzing a cone beam CT scan. It's primarily a Blair analysis. There's a few things that I've changed a little bit. I don't teach it. It's as part of Blair. It's not part of Blair, but this is what we do here at our clinic. We use the Mac software Horos, H-O-R-O-S, which is an open source software. And I think you have to pay a little bit of money to get the, so that it doesn't say not for diagnostic use. Get that off there. But let me just dive right in. The first thing that shows up is the documents screen. You can export, import. The top of the screen it has a little Apple symbol and Horos file network edit format, 2D view, 3D view. We are going to use that once or twice right at the beginning. We're going to double click on that, and that will take us to this view. Now, it's a little bit large. I'm going to shrink it down in a moment, but at this view, you'll notice that right is on the left, and left is on the reading right. And with a lot of other programs, you can set the default to automatically switch that. I have not found that with Horos. I'm going to go up to a little tab that says 2D Viewer up at the top, go down to Orientation, and I'm going to flip image horizontally. Boom, you can see it's got that now. There, it's got the left on the left, the right on the right. There's a couple of different things when setting up this program for the very first time, and one of them is there's a little tab called ROI up at the top, and I usually choose these things because then when I'm putting dots on the screen, it doesn't leave all the information. There's a plethora of information for each line, dot, circle that you put on there, and this way it just gives me what I need when I need it. Right, so I flipped everything. What's the first thing I do is now I'm going to go up here to under 3D Viewer. I'm going to pick 3D MPR. There's several different choices here. There's a curved MPR. For those of you who are interested in curve slicing, it doesn't seem quite as easy to use as Carestream 3D. I don't use the curved slicing per se. I do some curved slicing, but not by using a tool. And then there's a 3D volume rendering. So we're going to click on that. So you can see it's a pretty good reconstruction. It usually will start out a little bit more like where you can see the skin minus the hair. So we come up here, there we go, and change it to something that's going to look pretty decent. And then we can come up to this button, and now I can rotate. Now, I'm not going to analyze it using this, but I am going to get some ideas like, wow, see 2 on 3 looks like that might be forward on the left side. There might be something going on right here between C3 and C4 on the right side. I'll look at the mastoid processes compared to the transverse processes. See if that's going to be in the way of my adjusting. It's not for this lady. I'll look at the styloid processes, all those kinds of things, the jaw, and see how that looks. So overall, first thing we do is we look at the 3D just to get an overview. Now I'm going to keep this on my screen so I can go back to it if I want to, but what we're going to do now is we're actually going to go into the screen that I use, the 3D MPR. So we're going to pull that up, and we're going to size it properly. Now, there's a lot of times there's and I'm not sure why, but it'll come up and ask you a question. I'm going to throw that up on the screen here, and you want to select resample. I've done both. Then I did some research and looked up what was the ideal, and I don't remember the details now, but it was resample. So we hit resample, and then the screen shows up. Now it's going to be at the smallest. It's going to be set at the smallest slice that the machine that took the image uses. Mine, small slice, or the smallest slice that we took for this picture was a 0.3 millimeters. That, according to the radiologist, is too small to actually look at things. So we're going to change that around. Also, you notice here this is max intensity projection. That gives you kind of a 3D view. Let's go to 10 just so you can see what that looks like. And you can see it's starting to fill things in. And so interesting views, but I haven't found it to be quite as useful as the MPR view. So we're going to switch. We're going to go to MPR, or mean. Sorry, that's all the MPR view. The mean view, this is going to be more your standard CT X-ray like view, which of course is what all our procedures are based on. As far as plain film X-ray procedures, something that looks more like an X-ray. The smallest slice interval that the radiologists have told me I should look at is 3 millimeters. I'll typically start about there, 3. We're going to kind of go back and forth between about 3 and 20 millimeters at different times. And the first thing we need to do is we need to decide what our measurements are going to be measured to. So are we going to measure to the ground? And this is where we depart, at least right now, from the way that Dr. Blair did it with his plain film x-rays and what's in the Blair manual. What we want to do is have the patient in their habitual posture. Not normal, because they're probably subluxated, but their habitual posture. So we have them close their eyes when they're in the machine. Before we strap them down, we don't want to fit them to the machine. We want to fit the machine to them. So we can see in their habitual posture which joints are not lined up as far as possible. So we have the patient sit or stand in the machine. I have a seated machine, and close the eyes and stand across the room from them so they don't orient on your voice, but in front of them. And I have them turn their head to the left, back to the center, right, back to the center, down, and up to level. And I'm looking at the laser markings on their face and seeing if they're coming back to the same spot or not. And we might have them do it a couple times till I can get them pretty much in what looks like their neutral position or their habitual position. And then we'll move the back here, the brace, up to wherever one point touches their head or their upper back or whatever. And then we'll use a Velcro strap that goes around. That's my particular machine. So we're fitting them to the machine. That means that their head's going to be tilted a little bit. You can see that her head is tilted a little bit to the right. It's going to be rotated a little bit, maybe inclined or declined. So if we're going to measure things for adjustments, like we do in the Blair technique, then measuring to the ground probably isn't the ideal way, because when we go put the patient on the side posture table, we are changing their head position. They no longer have a head tilt. The head's pretty level. We get them more or less into a neutral position as opposed to their habitual position, and that changes things. Think about this. If you have a head tilt and you're measuring the slope of the left condyle, and then you straighten out that head tilt, well, now the slope compared to the ground, that slope has changed. So I wanted a three-dimensional reference point that was different. And so what I decided to start off with, I needed something that I could reference from the outside. So when I walk up to the patient with my protractor, I have a point of reference on the outside that's going to be pretty close to what's going on the inside. And the dental profession tells us that the hard palate is fairly equal to either the top of the external auditory meatus and the bottom of the orbit, or where the ear attaches to the skull, to the corner of the eye, somewhere in that region. And I found out some things. It's not super consistent, so we're going to play with that too, or at least we do at the Blair Clinic right now. But I'm going to put the back of my crosshairs right at the posterior tip of the hard palate, and we're going to bring it down to not along this line up here or anything else, but where that tip, wrong button, that tip right there. So when I'm taking my x-rays, I want to make sure that I get the hard palate and I want to be able to see all those spots. So if we bring it back, the tip, the posterior tip, the anterior spine of the hard palate, and I line that up. Now we're going to look in a minute at how that relates to the patient's ear for this particular person. But now we're going to take this back here, and we're going to line it up with the ear canals. Why the ear canals? Well, that's what Dr. Blair used. There doesn't seem to be a big reason to change that. When you're walking up to the patient, it doesn't seem to matter. The ear canals are not the same on both sides of the skull. A little forward, a little backward, a little high, a little low. People aren't made symmetrically. So when we start getting into millimeters and tenths of millimeters, it's not super accurate to know exactly what's going on. But when we were walking up to the patient, the next two planes aren't quite as critical. So I'm going to go ahead, and I can see them because they're the ear holes. Okay, we are going to find those. It's about right there. Bring that up. See, now I'm seeing it better here. I'm going to tilt. Now, I typically will try to find the center of the ear canal on each side, but mostly I want to be balanced with the bottom because that's closest to the foramen magnum. So we're just going to do a little twisting around until I feel like the occiput is pretty well lined up on both sides. For example, these lines here are pretty easy to see on the temporal bone. These are temporal bone as well, of course, but closer to the foramen magnum. So if I'm gonna need to pick which side of the EAM I'm gonna measure, if they're very asymmetrical, different sizes, I'll typically pick the bottom. Otherwise, I'm really just kind of centering them in there. And you can see in the center picture here, the axial view, again, pretty centered. So this is going to be what I measure everything to: slope angles, convergence angles, and convexity angles. Now, the interesting thing about Horos is that when I use one of these ROIs, the line, the length, the angle, the rectangle, oval, text, and then I move away from a particular spot, they disappear and they don't come back, except for this one here. So what I'm going to do is I'm going to put this point here. Now you see all this information there. That's why I chose up at the top the ROI. I wanted to only have it display info only when the ROI is selected and display info when the mouse is over it. Otherwise, it just all that information just, oops, that didn't want to go there. That's the other spot I'm going to do. All that information just stays there, cluttering up your view. So I'm not going to do the very bottom one. I don't really need to. And okay, now you notice they aren't exactly on the lines. Don't worry about that yet. We're going to come over here. And then I can hit the space bar. It gets rid of the crosshairs. And I'm just going to click on each one of these. And you'll notice over here, look at this one here, when I click on this. Well, that didn't center. Oh, because it's pretty centered from top to bottom. So this is centering those from top to bottom. And then I come over here, hit the space bar. Now watch that center one over on the far left, how that centers. So now it's centered front to back. So I just click on these real quick. And everything is pretty centered. That one doesn't look so great there. That's front to back. I think what I'm going to do is actively move that one. Okay, we're talking hundredths of a millimeter, tenths of a millimeter, something along those lines. We're not going to worry about it too much. All right, so this is my frame of reference now that I can always come back to because I have these points. So, for example, if I go to measure something, let's say the A to P sagittal plane line of the foramen magnum, I can measure it. It's going to be measured basically to the hard palate here. Boom. Okay. But if I move away, like if I move to the left, if I grab this here and go whoop, and then come back, it's gone, and it's not going to come back. So anything that you want to keep and come back to, use the dots. Typically what I'll do here, if I take a measurement, is I'll do a screenshot and write it down on a piece of paper. Okay, once we have the reference lines, the reference planes that we're going to measure that are not going to change based on the patient's posture, I want to see if the hard palate line is actually equal to, or how close is it to the line between the corner of the eye and where the ear attaches. And if it's significant, I will have a correction factor so that when I walk up to the patient, I can add or subtract a few degrees. So how do we figure that out? We are going to come up here. All right, there's the top. Top of the ear. We're going to come up. Good. All right. Top of the ear. Top of the ear. We can look over here. And I'm going to rotate this in. You can see the eyeball up there at the top of the screen. And you can see here's the eyelid come down to about right there. So I am going to angle. Now, if you want to test me on that, you can play with it. But there's the eyelid. There's the spot behind the ear. Here's our reference line, so there's the hard palate. So we can see there's a difference of 4.3 degrees. So I'm going to take a picture of that. This is on the right side. That doesn't mean it's 4.3 degrees on the left side. And it's decreased. So I'm actually going to add, when I have my slope and I'm walking up to the patient and I'm using my slope or my convexity, I'm actually going to add 4.3 degrees to my angle, just to be that much more precise. Do we absolutely need to? No, this works great the way it does, but if we can be a little bit more precise, why not? All right, let's go over to the left ear. 4.5, pretty much the same for this lady. She's fairly consistent from left to right, but 4 degrees is a fairly significant number in my mind, 4.5 degrees. So instead of just using the slope angle that we measured, I'm going to add 4.5 degrees to it when I walk up to the patient. So for right now, here we've got everything. What I'm going to do is I'm going to switch this over to 10. We're going to do some measurements. Right click on here, it comes back to center. I don't know why it goes off center. You notice it's off center on all of these, but we're still in the, it hasn't, none of these axes has rotated. So they're all still going to be good for measurement purposes. First thing that I do is we're going to do this measurement. Can't remember off the top of my head what it's called, but it's for kyphosis of the skull. We're going to do this, which affects the jaw and things like that. Good. Move these out of the way. We're going to do this and this one. So those other two we're not measuring to our reference points, but the sagittal plane line, move this over here. Now if I hit Command copy while it's selected and paste, now I don't have to re-straighten that top line. I always make the top line longer just so I remember which one is my reference angle. So now I have, and then if I go over it and I hit shift and click, shift and click, shift and click, it'll keep all of them. I'll take a screenshot, but I'm not quite done with this view yet. But here we have the sagittal AP plane line, the way that the Blair technique measures it. It's good for what we use it for. I have this one. I've been comparing these two over time. hopefully someday write a paper on what seems to be normal with an anterior atlas, posterior atlas, so on and so forth. Claviaxial angle, and that angle. Now we're going to come over here. I also measure this because sometimes, rarely, but sometimes we find that we need to adjust C1 in relationship to C2, and I kind of want to know what that measurement is. So this, again, is not a Blair measurement whatsoever, but it still is using the Blair principle of looking and measuring joints. Okay, we're gonna now I'm going to screenshot that. I'll write it down on my piece of paper. The next thing we need to do, well, probably one of the few things that I do in the very beginning is putting it on the 3 millimeters. I scroll back and forth through everything to be able to write down any pathology that I find. And we didn't do that in this particular tutorial. However, I would expect that everybody would do that. The other thing I did want to say is that I have some, it's interesting that the hard palate in maybe not the vast majority of people, the face and the calvarium are typically not lined up. I mean, you can see here, now I measured with the ears, right? That was this line here, but you can see she's fairly symmetrical compared to where her EAMs are at the posterior part of her skull. But look here, well, we got a little sinusitis there, but the anterior part, look, look at that vomer, the hard palate, they're all angled off to the right in her. So this is one of the reasons why I don't choose a central skull line for this. I instead choose something that we have traditionally used and don't really have a reason to go away from, but trying to find that central skull line when really I'm interested in adjusting the atlas to the occiput seems like I don't need to reinvent the wheel for the Blair technique. Right, so I've got all those measurements. I'm written them down. Typically, I will look at tilt and kink, the orthogonal concepts, and use that to help me decide which side to adjust a patient on, since most of our adjustments we can adjust from either side. And Dr. Blair found that the primary motion of the cervical joints, the facets, and the AO joint is anterior and posterior, not lateral. So laterality is secondary to anteriority to posteriority, and if it's gone forward, you can push it back from either side. You just use slightly different leverage points. All right, so here we are. What's the next step? Well, for a Blair doctor, we're going to reconstruct a base posterior and measure that. Now, I've been playing around with a couple of different ways of doing this. Fairly simple to do it the Blair standard way, which is find the notch here between the anterior arch and the lateral mass on each side, and where the posterior arch meets the lateral mass on each side. Now, Dr. Blair taught to use the foramen where the foramen magnum crosses, but as we thicken our slices, we start to lose definition, and so it starts to get harder to see exactly where that is, but it's still possible. So for example, on this one, this would be here. Now, the other thing that we have changed a little bit is that Dr. Blair would come in, base posterior, about 45 or 50 degrees. The Bucky would be 90 degrees to the tube, but we could play with it like this a little bit, and so we would be coming in much more like this to do those measurements. Most Blair doctors are using the AP plane line, the sagittal AP plane line of the atlas to use. And you can see how we start to lose some definition at a thicker spot, but we could use the foramen magnum line like we're supposed to here. They're at the same spot. But most people who've been doing this even longer than I have are using the where the posterior arch meets the lateral mass. We draw a line between those two, come out on each side, hit the outside margin of the lateral mass, not the joint necessarily, but the lateral mass. You bisect that line on each side and draw a straight line. That's the Blair technique. That's been going on for a long time. That's how Dr. Blair did it with x-rays. I found a couple of things. Number one, because we can move things around a little bit once we get the protracto view, once we get these angles, plus the angles for the adjustments when we're doing the adjustments are getting us generally into the right area. I tend to feel, and this may be only my, well, it's not only my opinion, but this is not the official opinion of the Blair Society, but I feel like we can fudge these a little bit. So this is what we are doing here. This is one of the ways. I'm going to come back here, find the peak of this. What I want to do is make sure that the thickness covers the full joint. So I'm going to bring this up a little bit, about right there. We can see the lateral masses, the top half of the lateral masses here. If I come back here and find the center of this arch, and then eyeball bisect the joint, typically the front of it ends up right in here somewhere. Boom, and I've got my right convergence angle. Now, because once I move away, that's going to disappear. I will take a picture of it, but so I can come back to it when I want to actually look at the joints. I'm going to mark it with these points that will not go away in 3D. And there's my convergence angle. I hang over this, hit shift, I got both. What we need to do now is we need to measure the slope angle and convexity. We've got our convergence angles, we need the slope angle and convexity for each side. So we're going to move over here. Before I actually analyze the joint, I'm going to do the measurements because I only want to rotate one thing at a time. Now I've already rotated this one a little bit to bring it into line with the convergence angle, the slope of the AP plane line, sagittal AP plane line of the atlas. So I need to undo that. Okay, so we're all back at center everywhere. Now we're going to go down to the atlas, and you can see I've got my marks there. And I want to measure these. So I'm going to come over here, going to line up my central ray with my calculated convergence angle. We're going to come back to the thickest part of the joint, usually right in front of the vertebral frame in there. And I can analyze this right now if I want, but I don't want yet. Sometimes it's really easy, but right now all I'm doing is measuring. One of the reasons I keep taking away the crosshairs and then putting them back is because if I accidentally grab this one, everything rotates. And then I have to go reset everything. It's a real pain. So if I'm going to be getting close to this line at all, I just take that out of the way. All right, so she's got a slope of 23.3. Now this is again, departing from the Blair analysis, usually when you're looking at a plane film, you'll see and you've got when you're looking at a plane film, it's a full thickness slice. We could get this slice thicker so that I can be seeing the convexity of the other side like we do on a plane film. In other words, if the view here was thicker, we'd be seeing the convexity, or at least how Dr. Blair did the convexity here, and we could measure the left convexity and the right slope. Well, it's actually a little bit more accurate, and it may not be necessary for our needs to be more accurate, but since it is more accurate, I measure the right slope and the right convexity at the same time. Okay, and that's a pure convexity because we're measuring right here. We're not measuring uh, different from the long axis of the joint. So when I bring this over here, I would be measuring here, not really and it changes by sometimes several degrees. So I like doing it this way. I feel like when I'm doing my adjustment where I need that particular angle, I am coming right in at that angle. I'm sure Dr. Blair, the reason he didn't do it is because he would have had to take another x-ray at 90 degrees to the convergence angle to get that pure slope line when he could do the adjustment, and it works really well without having it. So again, we're needing a ballpark figure, and but we can actually do a little bit better than that. So all right, I take a screenshot, I write it down. Now I'm going to come over here. Okay, we're going to pull back to just in front. So the interesting when we're talking about things, we need to have the same definitions, right? And so when we talk about the anterolateral part of the joint, Dr. Blair found that the most accurate place to look at the joint for it to line up is going to be parallel to the long axis of the joint at the point the most lateral from that. But it has to be parallel, but it's not the lateral part of the joint. That would be here. And so this is actually the anterolateral, but some people, this is also anterolateral. And this, he determined, was not a good spot because as the joint rolls forward, back and forth in life, the front of the joints don't mirror image. They don't line up in a lot of people, not consistently enough for us to use it. So if you're coming around that front lateral margin, you often will see an overlap when in reality it may be lined up. So we come to that part there where I want to look at it through the thickest part. And why aren't we measuring the convexity in radians or something like that? We really just need this for to know kind of the overall shape of the joint. So we're taking the posterior 1/3 of the joint. So here's the anterior 1/3, middle 1/3, posterior 1/3, drawing a straight line, and we're measuring that. And that's what we need. If we needed to be more accurate, as we think about how the bone moves and how much it's going to move, how much it's going to roll up when it goes anterior, then we would need to be a little bit more careful with that. But for our purposes today, and that's fun because then we start talking about, well, what happens to the opposite, transverse process? Does it actually approach this? If it goes forward on the left because it's rolling, is transverse process on the right going towards the spinous process or away from the spinous process? And it has to do with the combination, I think, of the slope angle and the convexity. And if you have a fairly steep slope and high convexity angle, you're going to get much more of a rotation or the appearance of a rotation of the atlas underneath the skull. It's not rotating in relation to the joints, but it's going to give you that appearance. Okay, so we measure that. Now I want to analyze this, and now I can start moving things around without worrying about the fact that I'm leaving my reference points, my reference planes. So I want to see this really clearly. So what I'm going to do is I'm going to move it up here. And a lot of times I'm looking at these actually at 5 millimeters. We're still at 10. Ideally, we should be looking these at 20, but we do start to lose some definition. So we're going to look at that in a moment. But I'm going to line that up with the joint there. We're still along the calculated convergence angle. And we're going to come in and I'm going to line this up to make that line tangential to the convexity curve. Okay, so now I can see fairly clearly that we have an overlap. Okay, now we're not looking at the whole joint. We're just looking at part of the joint. Now it's the most important part of the joint. In fact, if I wanted to come back here, now that I am along the joint, I can see that the most lateral part of the margin is here. So now I'm really looking at it where it didn't change anything over here. well, made it maybe a little bit more of an overlap. But I can come up here and change this to 20. Make sure that now we've got the whole joint there. Make sure that I'm got the clearest line here. But you can see how we're starting to lose some focus. So in this case, with this particular patient, there's no change. It was so obvious. It's such a large misalignment in the first place that that really we didn't really need to go any further. But typically, so we can go anywhere from that 3 millimeters all the way up to 20, and often it's a good idea to actually go through a few of them and make sure that, hey, everything still looks like at this lateral margin of the joint still looks like here. Now, if I'm wondering a little bit, maybe my convergence angle was right. Now, and I can come in 90 degrees. I mean, right along there. We can move this. So we're starting to lose that overlap, so that we're starting to go too far forward and see things that probably aren't accurate. But that's pretty good. Now, if we start coming back here, where the joints just are not mirror images, we're going to start getting all kinds of interesting different things there. It looks totally lined up. But this is the point that Dr. Blair determined most consistently was going to show an overlap or an underlap when it should be in juxtaposition or even. So we've done one. We're just going to do the same thing for the other. I'm going to just get these so I can see my dots. So there's my convexity angle, sorry, convergence angle on the right side. We're going to go back. Let's just keep it at 3 for the moment. We're going to line up everything. Looks like there might be a slight posteriority there, but I don't know that I'm in the right spot. I can't see my other angle. So let's go ahead and do this. Make sure I've got the right convergence angle. Now I'm going to make sure that I'm tangential to whatever point there. I'm going to call that even. We start looking too close, and the gnat's eyebrow is probably just going to lead to confusion. As I start moving backwards, I'm seeing a little more posterior, or not posteriority, but underlap. So I'm pretty sure that this patient is even on the right, and that underlap there is because it's the wrong, that we'll come back here is because we're starting to look at the wrong part of the joint. And if not, it is going to be a minor part of the misalignment. So I might write it down as an underlap. S for slight, small s. But this really, I mean, it's so obvious that she was anterior, superior, and left, the big overlap on the other side, that if there is a posterior, inferior, and left, it's pretty small. And if you really start looking at things, you're always going to find stuff that probably isn't there realistically. So again, remember this was a 3 millimeter, and ideally we should be looking at the whole joint. Dr. Blair initially, evidently, was shooting his x-rays straight down the atlas sagittal AP plane line. The problem is the orbit kept getting in the way, and so they started going through the maxillary sinus. That was one of Dr. Muncie's suggestions for Dr. Blair. Okay. So, matter of judgment, you could mark that as a small underlap. So, I have analyzed C1. And the next thing we do here at the Blair Clinic is we analyze C1 to C2. This, Dr. Blair said you don't get a misalignment there. He was generally right. But I have found a few times where it did seem like it was a major or at least a minor. And so I always look at it, even if I'm not going to be adjusting it directly, it will give me an idea maybe of how I want to adjust C1 so as to not make any rotatory C1 on 2 misalignment worse, and maybe I can make it better. So this lady, typically what I have found, if there's a large one, usually it's a compensation for C2 on 3. So for example, what we're seeing here, and I like looking at the back because that's the neural canal. Here's the back of C2, right? Here's C1. If we want to, we can line up our angles with the joint surfaces and just make things a little bit clearer. Okay, so we've got a little bit of posteriority of C1 on C2 on the left. It's not large at all. Pretty sure that's just a compensation, but I'm going to make a note because I might decide how I'm going to do my adjustment. Or I might, at some point she's not getting well, I might decide that we need to go back and look at that again and maybe adjust it. I also will look at if there's an open wedge here versus here. It's not going to tell me what's going on with the AO joint, but it is going to be telling me what's going on with C1 in relationship to C2. I think that's one of the biggest issues when we talk among ourselves as upper cervical chiropractors. Dr. Blair was so focused on the joints because if a bone misaligns, that must be where it misaligns, that when he's talking about C1, we're only talking about C1 in relationship to the skull. We're not talking about C1 being misaligned from C2 and the skull, which I think would be kind of hard to do if it was just one simple misalignment. It's like taking a cue stick and just hitting the atlas and it moves forward in relationship to the axis and the skull. Now, you turn your head and you get hit. Yes, there's going to be a chain, which should be logical. The problem is people get more than one injury. And so you're never sure if when you're looking at something, did all this, I'm seeing several misalignments, did all this happen at once or over several traumas? This one here, okay, slightly anterior, very slight. I'm pretty sure this is not going to play into this case, but I write it down. Okay, so that was extra, not Blair. Now what we're going to do is we're going to analyze C2 and below. So I'm going to go ahead and just put this at 5. We're going to bring this back to mean. And the first thing I'm going to do is I'm going to measure these. Now I am going to measure these to the ground. Why? Well, as soon as you adjust this and their curve starts to change, these measurements are not going to be super accurate. Now, do we need them to be super accurate? It doesn't seem so until the curve has changed quite a bit. So if you're adjusting lower cervicals, which I know most upper cervical doctors, non-Blair, are not. But if you're a Blair doctor and you're adjusting lower cervicals, and then after a while it stops working, you might want to retake your imaging and get new measurements because these will have changed. But we don't need them to be super accurate because we have a variable line of drive adjustment. We need to be in the ballpark. We want to be as accurate as possible. I think a friend of mine said, the art of a precise estimate. Okay, so now that I've got that line straight with the ground, now you can't do that with all CT scans. Some CT scans have cones, they don't cut off straight. So ideally, I would have lined it up with our crosshairs, but do that as may. Now that I've got that lined up, I don't want to have to remeasure every single one, so I'm going to hit Command C and then Command V. I've got 1, 2, 3, 4 joints, so I hit Command V 4 times. Now I can just come in and adjust the angle. And notice that I'm always moving things away. The other thing is I'm always measuring the lower joint. So as a standard, Dr. Blair determined that C2 misaligns in relation to C3, not C3 into C2. Now I have found sometimes where I think because of maybe the direction of the original injury was low going up and vice versa, that that sometimes I want to adjust C3 in relationship to C2, but it's not something we teach. All right, so now we got all the angles. So when we measure the atlas measurements, other than that convergence angle, because that's a algorithm. When I'm measuring the slope and the convexity, I'm measuring the skull because we're adjusting the atlas to the skull. When I'm measuring for the C2, C3 joint, I'm measuring C3 because we're adjusting C2 to C3. If C2 is misaligned, why would you be measuring that joint? Now, the reality is they're not usually that much different, but sometimes there can be a wedge. We're going to talk about that. So I've got that. I got those measurements. That's my left side. I'll write those down, take a screenshot. Now we're going to scramble over here before I analyze them, and we're going to do the same thing over here. And I still have that copied so that that straight line at the bottom, my reference line, is still good. I'm going to copy 1, 2, 3, 4 joints I need. So now I've got all my measurements. Now I need to do some analysis. Typically what we'll do here is where Dr. Blair said the front of the joint, a little rotation here, whatever level I'm at, the front of the joint is the ideal spot. The problem is it often runs into the sclerosis from the rest of the pedicle, so it's sometimes hard to see. So what are we going to do? Well, first off, I'm just going to see if anything is obvious and jumps out. You'll notice that these will disappear at the same time. When it's misaligned, like this one here, this might be posterior just because of how that's disappearing. That's just a clue. It's not ideal. So, but I'm going to run back and forth, see if anything's obvious. Nothing's super obvious there. If I can't see anything here at the fronts, I'm going to look at the backs. I'm not going to take that I'm not going to put a lot of weight on that, but I'll look at that, and then I'll go look at the parasagittal George's line and see, like, that one looks a little anterior. Could it be that the right joint on between C3, 4 is anterior? That one looks a little bit anterior. This one's angled forward a little bit. Could that make that one anterior? So if I think there's a misalignment somewhere, but I'm not seeing it clearly, I'll go and look at all these other little clues on both sides. Now also what I can do, so for example, we have some facet tropism. So let's do what we did before, and we're just going to actually look right down that joint. There's the tropism. You can measure it if you want. But now I've got a nice clear, let's get rid of those, and I can go back and forth. All right, I can make this 10 millimeters and get it in the center and just look at it, which more approximates of plain film or digital film x-ray. Again, you can see that we can't see the anterior margin. Now maybe there's a bump right there, but it's hard to see. The back doesn't line up, but we know the back doesn't always line up. So we don't know what's going on here. So I can, wiggle this back and forth. Sometimes that'll give me a clue. We can rotate here. Sometimes that'll give me a clue. But I might be stuck looking at the other telltales. Okay, it looks a little anterior here. If I move to the parasagittal George's line, it looks like maybe it's anterior, but I'm almost so close to it, I'm imagining it. What I'm going to do in this case is I'm actually going to leave this alone, knowing that we typically try to do too much. It's better to do too little initially. But the next thing I can do is we can do a vertebral canal analysis. So I'm going to come all the way down here to the bottom. I'm going to make that parallel to the back of whatever bone that is. We're 2, 3, 4, 5, 6, C7. And we're going to line it up with the back of the body and put it in the center of the back of the body. And look where it is here. Now, you'll notice that it's not symmetrical. come over here and see if there's any tilt to the body. If I roll forward, come on. It's not rolling forward because we're being cut off over here. I'll look at the disc, see if there's some disc wedging. If there's an open wedge on the left, that could indicate that the left joint has gone anterior or the right joint has gone posterior, because if it goes posterior, it goes inferior. If it goes anterior, it goes superior. So that would be something I'd look at. But basically, I've lined everything up with C7. Is that what I said it was, C7? I'm just going to go up one segment. Now, there is a little bit shift laterally, so I'm going to recenter it. The lateral shift, I don't really know what to make of at this point, but if I recenter it here, I'm not seeing any rotation of C6 in relationship to C7. Okay, now there's curvature in the spine, and that's probably what's giving us that lateral motion, or that lateral. If I just come straight up, we're going to do it again. Okay, I think this is C5. Now out here, we're looking, it looks like, wow, okay, that's a little bit forward from there. But if you look at the body looks like it's a little bit forward on the left compared to the right. Now it's so slight that, again, I'm not going to worry about it at this point. But I'm looking at the neural canal. I'm not looking out here at these because things are made asymmetrically. And maybe I just don't have it lined up over here. So we're going to, there, okay. Yeah. I'm going to call that unrotated. We're going to go up one more. Now we're starting to get, this is a little bit more obviously a rotation if you look at the posterior body. So I might want to go look at the left joint, see if it's gone anterior, or the right joint to see if it's gone posterior. But it's pretty close. It's pretty close, and we don't want to do things just to do things. I didn't get any indication on my neurological tests that she had any lower cervical misalignments, subluxations. So there could be some misalignments, but here it's not so clear. I'm going to make sure that I'm fairly good there. If I run forward, good. Okay, so it does look like we have a little bit of a rotation there. I would go ahead and write that down. It could be an anterior left or a posterior right. We don't know. Now you can have an anterior right and an anterior left, and if the joints are fairly symmetrical from left to right, you're not going to see any rotation. All right. Same thing if it goes posterior on both joints. Okay, again, looks pretty good in relation. Now we've already looked at C2 to C1, but you can see that if this is C2, all right, and we've got pretty good, we're pretty much in the center of the body. You notice the DENS is off to the right. We were noticing that, I didn't mention it, but we noticed it earlier. It's not a space issue here. It's not an instability issue because the joints there, at least to my thinking, the joints are all lined up. We're not getting overhangs, where the joints here are all good. It's just the DENS is off center. So we're going to look here. I've got the center of my line right in the center. Let's rotate it so that it's right along the back. You notice that the peak is a little off center. Okay. Interestingly, the spinous process is a little bit more centered than the peak of the foramen magnum. Now we're going to come up to the atlas, and it really looks twisted. So my mind is going, wait a minute, I didn't see that big of a rotatory misalignment between C1 and C2 when I'm looking at the joints. We're coming up and like this. So let's look at it again. I still don't. This lady is just made that way. That's going to be my conclusion. Maybe I'm wrong. Maybe it's something I'm missing. But if I'm looking down here at these joints, I'm seeing a small misalignment, a small rotatory misalignment, posterior on the left, anterior on the right, but not large enough to explain that big rotation between C1 and C2. So the joints actually look lined up It's just that the way her lateral masses are made is different on the right and the left, and so we're getting the appearance of a rotation, of a rotatory misalignment between C2 and C1. That's going to be my official analysis now. If I learn something more in the future, I will change my opinion. But right now, that's what that looks like. And that pretty much is the end of our analysis. We write everything down, send it off to the radiologist to get an official report from them to look at all the other little weird things. We'll have already looked at the jaw. We do find that the jaw and the neck relate to each other very well, and we do end up adjusting the TMJ joint to help the atlas stay stable, as well as other things. But that is the end of our analysis on a typical case. There you have it. It's February 15th, 2025. I'm sure it's going to change as I learn more, as we dig deeper into what's going on here. It's going to change, and that's fun. If you got any ideas, if you got some thoughts, let me know. I want to hear about it.